the invitation, and that's difficult to come after the excellent talks that we had. So fortunately, we will completely shift from the early stage trials to the very late stage trials. Have you read the paper? The paper. You were supposed to. I think Anne sent it to you earlier in the week. No, still not. It will be a hard time, okay, for everybody. Okay, so the idea was to discuss a very recent paper that came out, which was, and of course I have not my glasses, but the Euronet Field C1 paper, which is a huge clinical trial. This kind of trial, I hope that all of you will participate in the future because it's really a huge collaboration. 16 countries, 186 centers. This is a type of trial you should enroll patients, even if it is not very likely that you end up as the first or the last author of this publication. And this trial raised many different questions that we will try to address in this talk. In particular, non-inferiority trials, population-based trials, relative outcomes, absolute outcomes, interim analysis, multiple endpoints. So too many things, so we have to speed up. But first, okay, so we will see these kind of things. But I would like to have an initial question to all of you, and it will be a nice transition with what has been just discussed before about the patient number, the patients that you need to treat to avoid events. So it is completely outside of pediatrics and outside of oncology. It's back to the, I think, late 80s. It was a question raised, asked to general practitioners. You have 5 new agents that have been tested. Okay, with patients with dyslipidemia, and you have results from 5 randomized clinical trials. So it was a very active period of time, and it was asked to 150 general practitioners which one of the 5 drugs they would like to recommend for their patients, based on the results. The primary outcome was the cardiac event. The first trial, number A, showed an absolute risk reduction of 1.41% in the risk of cardiac event. The second one showed a relative risk reduction of about 1/3. The third one reported 87.3 patients without event versus 95% so depending on the arm, a placebo or investigational. The number of patients needed to treat to avoid 1 event was 71 for the first trial. And the last one had a reduction in the cardiac event, but also an increase in the mortality rate. So I ask you the question, which one of the 5 compounds, all of them were compared against placebo. So there was a common comparator, but it was not face-to-face comparisons. Which one would you like to recommend? It was all superiority trials. So A, you have to. That was a question too. So take your decision. And yes, of course, they are all the same. But of course, most of the people recommended the B, because it is a relative risk. And 35% reduction in the risk of event appear much more attractive than 1.41% absolute risk reduction. Okay, so we will see that we will have exactly the same question with should we have radiotherapy in Hodgkin lymphoma in patients with adequate response to initial treatment. Okay, it was an old trial, and the survey was by Bobbio, published in Lancet 1994. And you have the way to calculate based on the results. Okay, so the 2 objectives of the trial were to examine whether in patients with adequate PET and morphological response to 2 cycles of chemotherapy, radiotherapy could be safely omitted while maintaining the 90% event-free rate at 5 years. Okay? And the second question is to replace procarbazine with a potentially less gonadotoxic drug, dacarbazine. Okay? Everything which is in blue is directly cited quoted from the article. The primary endpoint was event-free survival, which was defined as lack of relapse, progression, death from any cause. Okay? And they wanted to look at it at 5 years. So there is, even if there is a much longer follow-up, it's 5 years cut-off date that has been chosen. Okay, question. What is the main difficulty if you want to show that you can omit radiotherapy? So first, are you in a superiority trial and a non-inferiority trial? Non-inferiority. What is the difficulty with non-inferiority trial in this particular setting? Why is it so difficult? Why it took more than 15 years to address the question? Follow-up time, more precisely, you are too good as physicians. A 90% success rate means that you do not have a lot of statistical power, and you need to increase your sample size. So that would be the very first point, and the second one is that you have some heterogeneity, as has been regularly discussed yesterday and the day before, across European countries or even across within countries. Okay, so just a short reminder, when you compute sample size with time to event endpoint, so typically event-free survival, progression-free survival, overall survival. Indeed, this is not a number of patients that the statistician will compute. It will compute, or she will compute, a number of events. And then, depending on the event-free rate, you can extrapolate how many patients you need in order to observe a certain number of events. So in addition to the usual type 1 error rate, type 2 error rates that have been described previously, at least if you're in the frequency setting, in addition to what we call the clinically meaningful difference, whether it is hazard ratio or difference in survival median or in rates at a given time t, you need to know that you will get a number of events. And of course, this number of events is just dependent upon what you call the clinical meaningful difference. In other words, if you need to observe 50 events, you will have the same power, the same statistical properties, whether you observe your 50 events in 60 patients with very advanced disease in which everybody will make the event eventually, or if you have 1,000 patients with only 50 events because you have a 95% survival rate. Okay, so here it's exactly the situation. One of the most curable pediatric and adult cancers with survival rates exceeding 90%, at least at 5 or 10 years. So large sample sizes are required to estimate the survival rates accurately or to compare treatment effects. So this is the first difficulty. So remember, when you have good outcomes, you will probably need more patients, even if you want to show the same clinical benefit, if you have the same type of trial as if you had a much worse clinical situation. Second point, heterogeneity. What is the impact of heterogeneity in our trials? Here we had 2 sources of heterogeneity. The first one is related to the disease because we had early, intermediate, advanced stage Hodgkin disease. And of course, the prognosis is not the same, but the treatment is not exactly the same. Here, they report only the result from the group 2 and group 3, so it's the intermediate and advanced stage disease. The second source, but you still have 2 groups and probably 2 different prognoses and possibly different treatment options or different intent of treatment. The second one is country-specific standard of care. There were 16 European countries, and the idea was that this trial should be accepted by all the countries in Europe. And of course, you know that you will have different standard of cares, different way of following up the patients, different ways of prescribing co-medications, and so on and so on. So in this trial, they tried to get some control on two aspects. The first one, which is probably the most important, was a reference pathology in order to have the same diagnosis shared across everybody. And it was a huge work to be able to make, in due time, this standard pathology report. And the second thing that was probably also a lot of discussions, as a result of a lot of discussions, the participating national pediatric classical Hodgkin lymphoma consortia agreed on a comprehensive treatment strategy for all stages of the disease. Okay? But what is important here is that they will try to use this apparent weakness, the heterogeneity, into a strength for the trial. Why? Remember that heterogeneity in the population or in the standard of care has some bad influences on the results of the clinical trial. First, it may dilute the treatment effect. Okay? If you have a huge heterogeneity, you may not see difference between groups because of the variations in population on standard of care. In other words, your prognostic factors have often much more influence than the treatment effect. So if you have variations into the prognosis, you may not see the effect. You increase the variability, and you may not be able to detect the effect. That is why often in clinical trials, we stratify on prognostic factors in order to have a homogeneous group of patients. The second thing is that you increase the risk of having different treatments effects in different subgroups. So if you have different characteristics, maybe the treatment will work better or less well in some subgroups. So in the end, what you get, your overall treatment effect, is some kind of average of several things. You have what we call predictive factors of response to treatment, and again, it will make more difficult to detect a treatment effect. But there are also strong advantages. The first one is it increases the applicability of the positive results. In other words, if you are able to demonstrate that in all countries in Europe, or in 16 countries in Europe, in 186 centers, it works, you have a much more applicable result as if you had done a monocentric trial. Okay? And this will be a way to address a public health question, and all the trial was set up, was designed to make use of this huge diversity in centers. And this is the notion of explanatory versus pragmatic trials. Usually, we try to make explanatory trials because we are influenced by pharmaceutical companies that just want to demonstrate that their treatment has an action, which is a bit different to the more general question is, if I implement this treatment in a population, will I have a benefit overall? Because we know that in randomized clinical trials, and typically the one that are sponsored by pharmaceutical companies, we have a very highly selected population. We have very high standard of care, very close monitoring, a very good compliance and adherence to protocol, because we have 10 people coming, checking the data, checking the process, and so on, which is not the case in routine practice. Nobody uses the RESIST criteria in routine practice. Okay, and we know that there are mistakes, we know that there are deviations to the protocol. So the question is, instead of doing an explanatory trial, can we use the huge diversity of practices in Europe in order to make a really pragmatic trial. And we will see what they have implemented, and we see how they did that. So we need large populations, and we need to have a care into the trial that is as close as possible from routine practice. The pragmatic trial aimed to include all patients available within an enrollment period of 6 years. This is the way it was written into the article. So you see there was the idea that everybody, all children with Hodgkin lymphoma must, I don't know, enter into the trial. And of course, it was the cornerstone of this protocol and of this trial. The consequence is that you can address only simple questions. You cannot address high-tech questions regarding the effect in submolecular groups defined by molecular pathology board and so on and so on. You can just address simple questions, but you need very large sample sizes because you will have a lot of heterogeneity. It implies also simple CRF, as simple as possible, a minimal deviation from routine practice. Otherwise, you're... So the Euronet PHLC1 was done like this. You had the stratification by stage. We will forget the stage 1. That was not part of this report. 2 cycles or 2 cycles of OPR, evaluation of the response, decision to go for radiotherapy or not, depending on how good the response had been observed after the OEPA, and then randomization between 2 chemotherapy, consolidation therapy, with COPDAC or COPP. Okay, so the radiotherapy question is not randomized. The 2 treatments are randomized. So there are 2 trials. One they call titration trial. I don't know why, but they call it titration trial, which is the non-randomized thing.
This was asked by one of the statistical reviewer of Lancet Oncology.
Stupid guy. It was not this reviewer. Usually titration is used for sleeping studies or for studies where you titrate in the blood PK concentrations in order to tailor the treatment. So anyway, this trial has 2 parts, and the second one is a randomized non-inferiority trial to compare the two agents. Okay, yes?
But it has never been a radiotherapy question in the study.
There was no radiotherapy question, but this is a primary endpoint, the primary objective. Mm-hmm. So they do not test it, but they wanted to address whether or not they could remove or omit it.
They thought that they needed more patients than they could get.
Yes, definitely.
And that was the reason that Hasenclever decided and Kurholz that there was not the possibility to have a radiotherapy question.
That is why we see how they try to address the question. Oh, here is an extract of the paper. And we will go back to absolute and relative risk differences, because here what they say, therefore, estimating absolute outcome measures is meaningful because we are in a pragmatic, large-scale trial. Our trial, the treatment titration trial, focus on absolute outcomes rates, by contrast randomized controlled trials that assess causal effect. So we will review the differences between the two. The trial asks whether a given treatment strategy is good enough, and we will discuss what it means good enough. And statistically, we replaced, says the article, estimating differences by estimating absolute outcome. Okay, so 97.3% that we had in the dyslipidemia prevention trial. Okay, so we will focus on those 4 points. And just to make a short reminder about the difference between estimation and estimate, it's not very important, but just to clarify what has been introduced by Harm before about the sample and the population, because everything is based on that. Here I took an eSmart Harm publication, so ITCC, you know, the European Consortium for Drug Development in children with cancer. So what I took here was a list of inclusion criteria, just to show you that in the end of the ISMART trial, at least of this particular arm, ribociclib, I don't know how to apply the results. To what population can the results be applied? Because I have so many inclusion criteria and exclusion criteria that the population behind that is just a virtual population. This is the population of Gustave Roussy cancer centers. I was a statistician for this trial, so I can talk about that, because we are doing an explanatory trial. We are just wanted to see in a very selected population with probably the best pediatricians in the world. No, I mean, in a very skilled network of physicians and clinicians, whether or not we can improve the success rate of very advanced population. So we have a full list of inclusion criteria and a full list of exclusion criteria. It goes up to number 15, so I just put 3 of them, and you can see it's very, you need to have patients, of course, with an advanced molecular profiling. Everybody has an advanced molecular profiling. Available and measurable disease, defined by criteria that we never use in routine practice. Performance status that is perfect, above 70%, and we know that, unfortunately, some patients may not be with as good performance status, and so on and so on. Adequate organ function, hematology criteria, cardiac criteria, renal, and so on and so on and so on. So this is basically a patient in phase 1, which is supposed to have a 3-month life expectancy, is exactly as anybody else in the street, except he has a very advanced cancer. Okay? So by contrast, here, we want to have, in a pragmatic trial, no inclusion criteria, except that they should have Hodgkin disease. Okay? And that is what exactly what has been proposed. I forgot to put it, I'm sorry. They have basically 2 or 3 inclusion criteria, which was Hodgkin disease, informed consent, and probably that's yes, and no indication for transplant or for things like that. So really the population that you see in your hospitals. Therefore, in the Hodgkin trial, you may expect that the sample that you will have into your trial is very similar to the population of your patients. And therefore, in this kind of pragmatic trial, you should be able to extrapolate to your population. Of course, this is only true to one condition. It's okay to have large inclusion criteria, but the question is, who accepts to enter into the trial? What is a selection that each center does? And we will see that it might be an issue with this kind of proposals. Next, they say, that a given treatment strategy is good enough in identifying some group of patients to target outcome. So, as said, the radiotherapy part was not a controlled clinical trial. There was no control. Everybody agreed to omit radiotherapy in a particular setting based on the morphological response observed initially. Okay? But still, if I want to take a decision in the end, whether or not it was correct to omit radiotherapy, or whether or not it should be omitted in the future, you need some criteria. And what has been proposed here is to say, okay, I don't want to compare 2 arms. I cannot do that because I would need 4,000 patients or 6,000 patients. But I would like to reach a level that seems to be good enough. And this good enough was set up to 90% of event-free survival at 5 years. This is not a statistical question. This is not even a clinical question. I think it's a committee-based question, because I think and I hope that the patient's representative had a word to say about what seems to be acceptable or not in terms of event-free survival rates. Of course, it will depend on what will happen at relapse, Because if you can salvage the child at relapse, you may accept to have some loss in efficacy, and so on and so on. So here, the basic idea of this part of the trial was to say, okay, we cannot randomize, but if we are large enough, if we are pragmatic enough, if we really make it to, if we really include all children with Hodgkin lymphoma, if we do not select our population, what we observe will be applicable to the general population. And then, if I am able to show that I have high control of the disease, then it will be almost as strong as a comparative trial. Yes?
But in this study, it was that we have had this quantitative PET after the first 2 cycles of EPA, and this was the decision tree we have had. When they were PET negative, we have had the decision not to irradiate them. So we have, and you see this, but unfortunately it's not published in this. In the T1 group, there were patients PET positive and PET negative for sure, and the most of them were PET negative and not irradiated. And I thought that we have had a publication of this, of T1.
Not yet.
Okay.
It is, yes. T2 and T3 have been published recently.
But I
not
think
T1.
what we should also add that in this trial we had a central review process, so for controlling for this heterogeneity you meant. All patients from all these 16 countries had a central review of the initial staging and then of their response assessment. So even we did this, of course, without randomization, we had this not only reference pathology but reference staging reference treatment group allocation, and whether a patient is really negative after 2 blocks or not. It was done by Gießen for all these countries. It was huge work, apart from France, and also we did it for our centers ourselves, the central review.
Okay, so the second advantage of this is that, of having a very representative sample, is that in theory, I should also have a good distribution of subgroups, because what I observe in my sample in terms of subgroups should be reproducible in the whole population. So in other words, the target that has been fixed should be also, is also applicable, or conversely, I can also evaluate subgroups and compare my subgroups to those 90% target. So yes, here are the inclusion criteria, 3 inclusion criteria. What is missing in the flow chart? You know, the very first flow chart that we have in the consort. Of course, it's difficult to read. So we have, yes, it's almost impossible to read. You have here the number of patients that have been enrolled, the patients that have been oops. Yes, the intermediate stage or high stage, the number of patients who have been embedded into the randomized clinical trial, and so on and so on. What is missing here is something that is very difficult to get. That is, yes?
I mean, it's like the expected number of people.
Exactly, the screening stage. Okay, the number of patients that have been screened. What I would like to know is whether the 2,000 patients that have been enrolled over 10 years, I think, almost, is it 80% of the full population, or is it only 20%? Or is it 80% in Germany and 5% in France, and so on and so on? So this information is very difficult to know because we do not have very good registries, or even if it's building up, that's difficult to have this information regarding number of Hodgkin lymphoma with stage 1 and so on and so on. So in our hospitals, I don't know whether or not there was any kind of selection. So if the patients who have been proposed to enter this trial were a subgroup of the population with some characteristics, I would not know. That is for, you should always be very careful with the demo, you know, the table 1 that we never look at, the table 1 that really report on the characteristics of the population to see whether or not it seems to have been over-selected for any of the criteria. Next, how to analyze primary objective. I do not have a control, so the question is, what do we mean, or what do they mean by 5-year event-free rate was consistent with a 90% target rate in patients with adequate response? How we define consistent? So, consistent means that what I will observe in my sample, I would like it to be close enough to 90%, even if I include the uncertainty around this estimate. So it is directly connected to the idea of confidence interval. If I have 90% estimated, if I know that my sample is representative of my population, and if I know that this 90% is embedded into a confidence interval of 89, 91, so if I am 95% sure that the true value is contained into this interval, then I would trust that I can omit radiotherapy and still have very good outcomes in terms of event-free survival at 5 years. Okay? So here what was missing was how large the confidence interval should be. It was defined for the non-inferiority trial, but not here. Okay? So be careful. What is important here is really the size, the length of the confidence interval, because the true value, this true event-free rate without radiotherapy, can be anywhere in the confidence interval, at least the 95% confidence interval. Second question, from a practical point of view, do we work on intent to treat population or on the per protocol population? So you remember that the intent to treat is everybody that is analyzed according to the intention to treat, so to the arm that has been assigned into randomized clinical trials, or to the intent to provide radiotherapy, and so on. And per protocol is what they have actually received. So what they say in the article is that they did both ITT and per protocol analysis, and they report results on the per protocol analysis because the study aimed to establish non-inferiority. But actually, it's not really a non-inferiority trial, at least for this part of the trial, even if that might be like this. And my question is, when they target 90%, is it 90% on the ITT population, or is it an observation of 90% event-free rate at 5 years in patients who could be treated with radiotherapy? Okay, so these small details, but you see that in the article, they report both results, and we will see the influence on the non-inferiority trial. So here are the results. On the left-hand side, we have the survival curves of the patients with adequate response who received radiotherapy and who did not receive radiotherapy, and patients with inadequate response who received radiotherapy. And so the idea was to say, can we reach the same level of control of the disease by targeting who should receive radiotherapy or not? Okay, what here is a bit frustrating is that we have a 5-year follow-up time. Instead, I think that the last patient was enrolled in 2013, so more than almost 10 years ago. So additional follow-up will be absolutely essential. But of course, it's very expensive to collect follow-up. So try as much as possible to have updates. Even if you do not have continuous follow-up, 10 years later, try to organize an update of the event-free rate, because we need long-term follow-up, especially for this kind of trial. And the other figure here is some kind of forest plot. It is not hazard ratios. It is point estimates of the event-free rates with the confidence intervals, which shows that overall, in all patients, we have 88% of patients without event at 5 years, with a confidence interval ranging from 86 to 90. So you see we are including 90. And we have dozens of subgroups. Here, you see that when you count everybody, you have a shorter confidence interval, as in subgroups where you have less patients. And the question is, what do you conclude in the group of the stage 3? Do you feel comfortable with omitting radiotherapy or not? And what I do not like in the forest plots, this one or any other forest plots, is that they are impossible to interpret correctly, because they do not aim at giving you evidence that it is valid or not valid to use radiotherapy, because the study is not powered. You do not have enough patients to address questions in subgroups. So of course, in the discussion, they say it is just exploratory, you should not draw definitive conclusions, and patati and patata. But in the end, we always interpret the forest plots in an erroneous way. We tend to say, oh, here it seems to be a bit dangerous for those kind of patients because, and so on and so on and so on. Okay? So be very careful, and this is clearly said in the article. You expect to have random fluctuations between subgroups. It doesn't mean that there is no difference. It doesn't mean that there is a difference. Okay? So be careful. The only result that is really trustable is the last one in all patients, because at least you have more than 1,000 patients. You have a narrow confidence interval. You make use of all information. All other things might be true, might not be true. That's very difficult to know. But unfortunately, too often, clinicians tend to overinterpret those forest plots. Okay. So what is a causal effect? A causal effect is the ability to say that if you get an endpoint modified by the treatment, if you see a difference between the two arms, this is a consequence. This is caused by the intervention. Okay? Without a randomized clinical trial, unfortunately, you cannot draw causal effect conclusions. Okay? As soon as you have a single-arm trial, as soon as you do not randomize, you make case control, propensity score analysis, whatever nice statistical methods that you would like to use, you will not be able to derive causal effects. Okay? That is why, if we look at the wording in the paper, it's never said that omitting radiotherapy caused the target rate to be 90% or still be maintained at 90%. They just said it is consistent with an acceptable EFS rate. This is a result of the whole treatment strategy, but also follow-up and also selection of the patients. Okay, so now let's look at the more classical non-inferiority trial. They want to replace procarbazine with dacarbazine. So the idea is to say that we would like to show a non-inferiority by excluding a decrease of 8% in event-free survival rates. So the whole question, the usual question with non-inferiority trial, is this non-inferiority margin. How do you evaluate an 8% decrease, loss? So in other words, the idea of non-inferiority is to say, I gain a lot in terms of late toxicity. Okay, it could be in terms of price, it could be in terms of whatever you want, but here it's clearly fertility, toxicity, long-term toxicity, and there is no free cookies. If I remove one of the drug, I may lose some activity in terms of event-free rate. How much I am ready to trade. Here, it was set up to 8%. How does it sound to you? Acceptable, not acceptable? And that's an important discussion. This is not a statistical one, that's a clinical one. So just to give you another insight, do you have any idea of what it means in terms of hazard ratios? It's almost 2. Okay? It means that if you had a hazard ratio of 1.9, if you have a hazard ratio of 1.9, it is equivalent to this decrease in 9%. And of course, if I was able to show that adding radiotherapy reduced the risk of event by 50%, so a hazard ratio of 0.5, which is exactly equivalent to losing in terms of 1.9, I may say that it is superior. So you see, this is an important discussion. And of course, in practice, how do we make the sample size calculation? So statisticians say, okay, if you want to lose 4%, you need to enroll 5,000 patients. So you start negotiating, and you end up with something which is acceptable. Okay? So how do we do non-inferiority trials? Usually when you have a superiority trials, this is simple. You try to demonstrate that your hazard ratio, or your difference in terms of absolute difference, is statistically significant. It was clearly explained before, p-value before 0.005, that just let you know that you have shown that there is some effect. Okay? Or you can also use a confidence interval. Here, my confidence interval excludes the null value. I'm happy. Here, it does not exclude the null value. I cannot conclude that there is a difference. I cannot say that there is no difference. I just say it is inconclusive. Okay? For non-inferiority, this is much more difficult because if it is non-inferior, or if it is equivalent, I should be right in the middle of my 1. Okay? So the question is how much uncertainty I have around that. Is it like this or like that? And all the way to design a non-inferiority trial is to see how many patients should I include in order to be able to reduce my uncertainty to something which is acceptable. What does it mean acceptable? It is that it exclude the non-inferiority margin. Okay? So typically, here I fix a non-inferiority margin. It's not 1.12 in this case. And I say that I would like my confidence interval to be on the left-hand side of my non-inferiority margin. It can be greater than 1, so it can indicate the detrimental effect of the treatment, but I would like to exclude this value. So here I should have put not 1.12, but 0.09, and should put a scale here that is 0. So if I am here, I'm superior. Here I am non-inferior. Here I am inconclusive. Here I am inferior. Okay? So the sample size was calculated in order to be able to be on the left of this value, of the value 0.09, hoping that you are more on the left than on the right. Officially, it is said in the recommendation that the non-inferiority margin should be half of the difference that you would like to target into a superiority trial. So if you are ready to go for a 50% reduction in the risk of event, then non-inferiority margin should be a 25% reduction, or a decrease. In practice, it's how many patients I can enroll. How much time do I have?
5 minutes.
5? Okay, perfect. ITT per protocol, non-inferiority, we sometimes prefer to use per protocol, as I said, but it raises questions. For instance, here, 150 patients refused to be randomized. Okay, so if I do the per protocol, I may change the balance between prognostic factors. So in the end here, we had some unbalance between the adequate response percentages between the two treatment arms, and it's not completely clear which one of the two set is the best. That is why in the article they have reported both of them, and we will see how different they are. Do we include interim analysis in non-inferiority trials? Usually, why do we use interim analysis? To complete follow-up, to be able to report results earlier, to be able to stop accruing, if we are still accruing patients, earlier. So in order to complete the trial at an earlier time point as the one that was anticipated. The point is that that's very simple with superiority trial. This is much more complicated with non-inferiority trials. So here what they said in the article was annual interim analysis was scheduled after the third year to monitor for unexpected superiority. So you cannot have interim analysis to stop your non-inferiority trial because you were able to demonstrate non-inferiority. Because we know that to demonstrate non-inferiority, I need to accrue all events. In superiority trial, if I have a very strong effect, I can demonstrate a very strong effect on a smaller number of patients. Non-inferiority trial, this is not possible. That is why, in this protocol, what they had decided, which is a usual standard, is to look for unexpected superiority. What is a bit surprising is that they have decided to stop randomization because of a perceived, this is the wording in the article, change in the risk-benefit assessment with emerging evidence from interim analysis of this trial that the two were similarly efficacious. Okay? So it's not clear what was the criteria to decide to stop randomization, and we will see that we will be missing some information in the end. Here is the difference between the two arms, or the lack of difference, I don't know. Okay. What they observed was a difference of 3.7%, with a 95% confidence interval ranging from 8 to -8 to plus 0.6. It means that the loss is somewhere between these two boundaries. And in the per protocol analysis, this is less. The loss is a bit less, is 3.1 instead of 3.7. Okay, so very close, and as anticipated, the per protocol is probably more relevant in this setting. On the contrary, the results on the toxicity were very clear. There was a clear superiority in terms of fertility, which was preserved in more patients. Just keep in mind that it was analyzed in a very small subset of patients. So again, that is a question of how representative this subset of question is compared to the whole population. But it is in line with what was expected, with the rationale, with the biological effect. So all the question is, do we have a good trade-off? And this is clearly a question difficult to address. It is not a statistical question. There is probably some loss. This loss is probably different across subgroups, but we don't know. And there is clearly a gain. How much are we ready to lose? Okay, so I will stop now and just say it was a fantastic trial with a huge international collaboration. Definitely. You know, I'm used to the eSmart phase 1 trial with 20 patients, so 2,000 patients is just a dream. Okay, I think it's a benefit for patients and community because it raised the standards of care everywhere in Europe, which I think one of the main benefits from the trial. Can we omit radiotherapy? I think it's not completely clear. This is debated. Can we replace one treatment by the other one? Again, there are some discussions because what you will see in the paper is that depending on whether or not the patients had an adequate response, the loss was a bit different, not statistically different, but the observation was raised questions. Thank you very much for your attention.
Thanks a lot, Xavier, for looking at our paper in such a detail. So it would be minor revision for you if you would have get this, or major revisions.
No, The paper is fantastic, and it's very good that it was published in Lancet Oncology.
Thank you. So, perhaps time for one or two questions, then we have to continue. Kathy?
Well, just a comment really. In the paper itself, they say, we expect we should be able to do this study in 6 years, but it took them 15. I think that's what it said in numbers. But surely the countries that are participating, they know exactly how many Hodgkin's lymphomas they have in that time interval. Could you not estimate what proportion of the supposedly eligible population took part?
I was looking for this information, and I couldn't find it. I looked in the protocol where they provided many results, but mainly in Germany or for previous trials. But typically, I would have liked to see in France how many Hodgkin's do you have, at least in the participating centers, and what was the proportion that was enrolled into this initiative. And I think it should be provided whenever possible.
One reason why it took it so long time was that lots of data were missing on the CRFs. It took years to get all the data on the CRFs from all the different countries and centers to have a final data set. This was a big problem. It took. Yes, that's why I did not react. But it's for me, of course, for me it was simple CRFs, but many countries had many problems to provide everything for a final analysis.
The registration period was 15 years.
Yeah. No.
It was about 10 years.
Yeah, it was short.
9 years, I think. I think CRF should always be.
From country to country. So Germany started first, and then after half a year or 2 years, other countries entered into the study.
Yeah, we know that opening centers outside
in
of
many
the country is
trials,
always a nightmare.
Yeah.
But just keep in mind that a CRF should be always simpler. So when you have completed your CRF, try to remove 1 out of 2 questions. And I think you will start having a CRF that is readable. Typically in this kind of study, you just want to have event-free survival. You needn't to know whether or not they took the treatment. You needn't to know what was the adverse events. I don't care about adverse events for this kind of trial. I mean, except for the non-inferiority for comparing the 2 treatments, but the 2 treatments are well known. You know perfectly well the effect of radiotherapy. You will not use this kind of data. What you want to know is whether or not 10 years later patients will have a relapse, they will have a secondary cancer, whether or not they will have children themselves, and so on and so on. So try to reduce the size to what is really presented to the community.
But we want to do